Hi everyone, my name is Chris Schneller. I'm one of the PICU doctors here and I have a strong interest in pediatric delirium. I've also utilized the Cornell Assessment for Pediatric Delirium tool many times in my fellowship and in my research career. And so I was asked to put together a short video to explain the who, what, where, when, and why we're utilizing the Cornell Assessment for Pediatric Delirium screening tool now in our ICU. As you know, we rolled this out about a month ago, along with RASS scoring to help improve our approach to reducing delirium and improve our sedation management in the ICU. Now, prior to watching this video, please reference the actual CAPD screening tool supplementary material provided before, so you have an understanding of what I'm talking about, as well as the developmental anchor points for patients between the age of 0 and 24 months. Now, as you can imagine, it might be difficult to know whether or not a patient is making purposeful movements when they're 6 months of age. So these developmental anchor points will help you answer the questions in the CAPD screening tool for those younger patients. To get started, let's just review. Delirium is a metabolic encephalopathy that occurs on a waxing and waning spectrum. There are three main types of delirium. There are hyperactive, hypoactive, and mixed. Hyperactive delirium is usually what you picture when you think someone being delirious. Hallucinations, agitation, ripping at essential devices. But hypoactive are more of your flat affect, kind of slow, very depressed, blunted individuals, and that's also a big problem in pediatrics. And then obviously mixed delirium is a combination of the two. And so now that you know this, you now know why we need to start screening for delirium. And I'm going to walk you through which patients need to be screened. Well, the short answer for that, just right off the bat, is pretty much all patients. So if a patient has a RASS score greater than or equal to -3, we ask that you institute delirium screening. A better way to think about that is whether or not they have spontaneous eye opening. So your patient that's in a phenobarb coma or paralyzed and sedated usually won't benefit from CAPD screening, but your patients who are intubated, sedated, and ventilated with a RASS goal of -2 should definitely get screened for delirium. Now, what is the CAPD score and why are we utilizing it? Well, it's got some great benefits. First of all, it's fast and validated for the most common types of delirium seen in children. It is a reliable and observationally based tool. So you can assess your patient over a certain time period and then answer the questions based on your own perception of what's going on with that child. And that makes these screening tools a lot easier. It is 8 questions that are graded on a Likert scale from 0 to 4. So usually the higher numbers means that the patient has a higher likelihood of having delirium, but it's very important for you to know that this is a screening tool only. It is not diagnostic, and I'll talk a little bit about that more in just a second. Now, when are you to initiate delirium screening on your patients? Well, we ask that you do it just once per shift. Ideally, we would like you to do it towards the end of your shift at 6 p.m. and 6 a.m. so you have an 11-hour window to assess the patient and apply your assessment to the 8 questions. However, we recognize that that time period is incredibly difficult. So we're asking right now that you attempt to do it both at noon and at midnight. 5 hours gives you a pretty good time between assessments to kind of get a good grip of what's going on with your patient. And we ask that you initiate it if you're getting a new admission at the beginning of that ICU admission if they meet criteria based on RASS scoring or spontaneous eye movement. Now, where are you going to find this in Compass or in Power Chart? Well, it's usually ordered by our frontline providers or nurse practitioner or residents, and it's charted under the vitals and pain section. So right below the sedation section where you're charting your RASS scoring. The developmental anchor points, if you hover over, can click on that and actually utilize that to reference for your younger patients less than 2 years of age to help you fill out the questionnaire when you are doing it. Now, I think a lot of the big questions is why are we adding another screening tool onto your already busy day of charting? And it's just incredibly important that we get a grip and we recognize how delirium is impacting our unit. The evidence is robust that reduction in delirium improves overall patient outcomes. from decreasing length of hospital stay, decreasing time with mechanical ventilation, reduction in morbidities associated with sedation and mechanical ventilation, and overall less iatrogenic comorbidities that we oftentimes can do to our patients. It also helps with this screening tool, your attendings, your frontline providers, NPs, and residents recognize the increasing concern for delirium in your patients, because we're bringing up this screening tool on day and night rounds. We're looking at this screening tool on a spectrum. Now, one of the biggest questions I get about the CAPD is, what is the score that makes you concerned for delirium? And my answer to that is there isn't one. Now, ideally, a score greater than 10 always suggests delirium, but that's just not the case. Now, a score greater than 10 would make you concerned about it, but if you look back at the questions, you can see some of our patient population have baseline CAPD scores of 12, 13. A lot of our patients are nonverbal. They don't make purposeful movements. It's difficult for us really to assess that. So we need to utilize the CAPD on a spectrum, right? We look at it, if they came in at a 12 and they're now up to a 19, 20, is that concerning? Now, the goal of all of this is for your providers to know how you are feeling as nurses dealing with these patients day to day, and for us to try and improve the management of these patients non-pharmacologically, right? So delirium is best treated when we normalize the environment, right? Give spontaneous breathing trials, have adequate day and night cycles, reduce noise at night, keep the blinds open during the day, have stimulus and bundling and clustering of care all around that same time period, reducing the frequency of labs. All of that helps us gear our treatment goals and improve outcomes in our patients. And so ultimately, it's up to your providers to work alongside you to reduce the incidence of delirium in our unit. If you have any questions whatsoever, please find myself, find Alex Wilson, talk to us about this screening tool. We will happily answer your questions. And please reference those supplementary materials provided, and good luck. Have a good one.